Hello, my friends, and welcome. I'm truly glad you're here. And whether you're listening as a prescriber, a psychologist, a primary care clinician, a therapist, a trainee, or simply as a curious human being, welcome one and all. And thank you for giving me your time. Time, of course, is a non-renewable resource, and I really don't take this time together lightly. And today, our conversation is about humor, but not humor as entertainment. No, but not even humor as a distraction. And certainly not humor as a source of denial. But what I'm talking about is a deep conversation about humor because humor is a core psychological skill and about its often overlooked but scientifically grounded role in, you got it, positive psychiatry. Now, I would like to begin by acknowledging something really important. For many of us, particularly clinicians, the idea of humor in psychiatry can feel uncomfortable, perhaps even risky, because, we are trained, I think appropriately, to take suffering seriously. We sit with despair and trauma and grief and suicidality, sometimes even psychosis, and almost always profound human pain. And somewhere along the way, many of us absorbed an unspoken rule that serious work requires a serious demeanor. And humor, quietly and gradually, was shown the door. But you know what? Here's the paradox. Because across cultures, across history, and across every major human catastrophe, people have used humor not instead of suffering, but alongside it. Viktor Frankl, he's a psychiatrist from decades ago who wrote the following from his own lived experience of concentration camps, and he described humor as another of the soul's weapons in the fight for self-preservation. This is a brief but powerful way to rise above our circumstances, as he said in Man's Search of Meaning, which was published in 1959. So, clearly, humor does not deny horror, but it makes survival possible. And positive psychiatry is, at its core, about understanding how humans survive and how they sometimes even grow under conditions that could have crushed them. And humor turns out to be one of those skills. Now, before we go any further, we need to be really precise about what we mean by humor, because humor isn't a single thing. Look, humor is not sarcasm, it's not mockery, it's not dismissal, it's not about minimizing pain. Those are all defensive maneuvers and often maladaptive ones. Humor, at its psychological core in its healthiest form, is far more sophisticated. Humor is the capacity to detect incongruity, a mismatch between expectation and reality, and to resolve this mismatch in a way that kind of feels safe rather than threatening. Now, this is not a philosophical idea. This is a neurocognitive process. There are, in fact, neuroimaging studies that demonstrate that humor processes information differently in the brain, and it reliably engages the network that involves the prefrontal cortex, the temporal lobes, the anterior cingulate cortex, and of course structures that we care deeply about, like amygdala and the mesolimbic reward structures. And this really happens when one is listening to a joke and is trying to understand it, sees the incongruity in it, and then there is a subjective experience of amusement. So really, if you rephrase it, humor is not a reflex. It is actually cognitive work. It's emotional work. It's in fact neurobiological at its core. And this matters because psychiatric illnesses systematically disrupt the very systems humor depends on. So think about it. Depression narrows cognitive flexibility. Anxiety locks attention onto threat. Trauma freezes exploratory play. And burnout, of course, completely erodes curiosity. So when humor disappears in psychiatric illness, it's tempting to conclude that something essential has been lost. And here's where the evidence tells us a more hopeful story. Multiple studies examining humor perception in major depression demonstrate that individuals with depression, in fact, do retain the ability to understand and cognitively process humor, even when their emotional responsiveness to it is blunted. So let's rephrase it, shall we? What we now know is that the humor capacity is largely preserved. What is impaired, though, is access. So, this distinction between capacity and access is foundational to positive psychiatry because capacity implies identity and access implies reversibility. So, if humor capacity is preserved, then you know what? Humor enjoyment can be completely reversed. Isn't that exactly what we, those of us who believe in positive psychiatry, would like to know and believe? So traditional psychiatry has done, as we know, an exemplary job in symptom reduction, and we've become pretty good at lowering the PHQ-9, the GAD score. But positive psychiatry has always asked a different question. It has always asked not what is broken, but also what is strong, what still works, what has survived, what brings even a flicker of vitality. And humor perfectly fits here. Because humor isn't about denying reality, it's about relating to reality differently. And in this podcast, I'm going to give you the neurobiology of humor in normal and in depression states, but also offer you a large number of techniques that we can use to help our patients. Meta-analytic studies, a lot of them demonstrate that laughter and humor-based interventions in fact do produce moderate to large improvements in mental health outcomes. This has been shown. In fact, the effect sizes of humor intervention is comparable to many established psychosocial interventions. So the effect size in some studies is anywhere from 0.59 to 0.61 and all the way up to 0.74. And these are not trivial effects, as you know. These are clinically meaningful changes. And yet, if you think about it, when is the last time we prescribed any humor-based interventions for our patients? I think part of the reason is we clinicians ourselves forgot that serious work does not require an attitude of humor deficit. It doesn't. So humor, like anything else, if it's used poorly, can absolutely damage trust. And humor used to avoid emotion or minimize pain, well, that comes across as defensive and in fact can be damaging. But avoiding humor altogether carries its own cost. So when we remove humor from our clinical work, we risk creating emotionally flattened spaces where seriousness becomes synonymous with safety. And in reality, humor is often a signal of safety when there is gentle, kind, and playful humor between a patient and their clinician. There's in fact a signal of safety, not the other way around. So from a neurobiological perspective, humor does require a temporary down-regulation of threat processing. You can imagine how good this is because so many of our patients are stuck in fight or flight modes, and humor emerges only when the nervous system detects sufficient safety to allow cognitive play. So this makes humor not just an intervention, but also as a marker. When clinicians show gentle humor or patients show gentle humor, they're literally saying, I trust you. I trust you to the person who's across from them. Now, Humor deficit is particularly problematic in depression and anhedonia. It truly is. Humor, interestingly, engages precisely those neurobiological systems that are less functional in major depression, particularly if anhedonia is present. And importantly, humor does this without requiring sustained effort or prolonged pleasure. So it's not like a 6-week course where you do hours upon intervention. Not at all. We are really asking for smaller and more achievable steps. And small steps matter when our patient's energy, as you know, is at its low. And patients are kind of afraid that if they laugh or even smile, others may assume that their suffering is not real. So they may have taught themselves to suppress the humor, as if it's not bad enough that their psychiatric disorder steals humor from them, but they may have taught themselves that if they possess any sense of humor, others won't take them seriously. It is our job to find in our patients the ability to experience humor, to express it in a safe manner and in a safe fashion. At this point, let me just be very clear. Humor is not optional for flourishing. A life entirely devoid of humor is really not a fully lived human life. Because humor binds us, humor softens us, humor connects us, and it helps us metabolize the absurdity of life. So positive psychiatry is not about erasing suffering. It's about expanding the psychological space in which suffering is held. And humor truly is one of the more humane expansion tools I have ever encountered. So, of course, this brings us naturally to the next question. If humor is so powerful, what exactly is it doing in the human brain and in the human body? And this is where we are headed. So now that we've established that humor is preserved in capacity but just blocked in access in many psychiatric illnesses, let's go where clinicians always want to go. We want to talk about mechanisms. Because once we understand mechanisms of what humor is doing in the human brain and in fact in the body, it becomes very difficult to dismiss it or to just reject it. Now think about it this way, folks. Humor is a biologically efficient intervention. Let's begin with a critical point, because humor is first and foremost a cognitive event, not an emotional event. So before we laugh, before we smile, before we feel pleasure from a joke, there's in fact thinking. So specifically, humor requires the detection of some kind of incongruity, a mismatch between what the brain predicts and what actually happens, of course, followed by the safe resolution of that mismatch. This process is deeply cognitive and, in fact, activates the prefrontal cortex and the temporal regions. As you can imagine, these are the very regions of great interest to psychiatry because those regions become cognitively inflexible as an early casualty of psychiatric illnesses. Well, guess what? The humor intervention we're talking about reverses it. It, in fact, attempts to correct that problem because depression narrows interpretation. Anxiety makes predictions rigid. Trauma locks the cognition into threat templates. And here's the magic. Humor gently pushes cognition in the opposite direction. This is, in many ways, the greatest strength of humor-based positive psychiatry interventions. Very interestingly, dopamine enters the story on humor as well. So even though we've often thought about dopamine as a pleasure neurotransmitter, in many ways the reality is that dopamine is also involved in learning, motivation, but also salience detection. And humor is all about salience detection. So, dopaminergic neurons fire when there is a mismatch between what is expected and what the actual outcomes are. Exactly what a good joke is, exactly what good humor is. So, humor reliably produces this kind of benign prediction error. And we, in fact, have functional imaging studies. I have reviewed two from Mobb and colleagues and Wild and colleagues, both published in 2003, the first one in Neuron, the second one in Brain, that showed that the humor interventions activate the mesolimbic dopaminergic circuitry, which significantly stimulates the nucleus accumbens and the ventrostriatal prefrontal cortex. And these are regions well known to us as regions for reward learning and motivational drive. So we thought humor was nothing but a good joke. Who knew that it's a great intervention at the neurobiological level? And this has really strong implications for anhedonia. In particular, anhedonia, because humor directly trains these impaired systems we just talked about without requiring sustained effort into correction of the neurobiology of these very disorders. We should also not forget that besides our dopaminergic system, our endogenous opioid system is also activated. Laughter, particularly shared humor, stimulates the release of endogenous opioids, and this has been demonstrated through both behavioral and neurochemical studies. There's a study I've reviewed from 2012 by Dunbar and colleagues that reveals that even pain tolerance following laughter-induced intervention is altered, and the primary mechanism for improved pain tolerance was, you got it, increased release of opioids, endogenous, healthy, normal opioids by us when we engage in humor. So when people say, I enjoy laughing, I get a lot out of it, you have no idea how right they are. They are giving themselves literally excess extra dopamine, but also endogenous opioids. So, we've heard people say laughter is good for you, but that's not a metaphor. That's actually physiology. So now let's layer in stress, because under conditions of perceived stress, the brain does shift into a survival mode. And a survival mode is, as I said, survival. And therefore, cortisol rises, attention narrows, our exploration shuts down, and you can only imagine what happens to humor, right? That's right. It is one of the first casualties of hidden stress that we face. And studies have shown that laughter and stress physiology show reduction in cortisol and epinephrine when they're exposed to humor. In addition to that, when people are exposed to humor interventions, it's not just they feel better, even the immune markers such as natural killer cells are in fact more functional. And there are studies from 2003 by Bennett and colleagues in Alternative Therapies in Health and Medicine, and that same group published in 2009 Evidence-Based Complementary and Alternate Medicine Journal, where they looked at really something I've ignored for really the entirety of my career, which is humor as a clinical tool. So the effects can be modest, obviously, with one humor intervention. So watching one sitcom isn't going to reverse anything, but living a life that is infused with humor from multiple sources, which we will be addressing shortly, can in fact make quite a difference. So I think at this point we can safely say that we have established that humor engages the dopaminergic reward learning. We can equally safely say that humor interventions activate endogenous opioids. We can say with great confidence that humor interventions reduce stress physiology and interrupt rumination. We can also say that when people are engaged in humor appreciation, their attention is captured appropriately. and humor enhances social bonding. These are core principles and core foundational principles of positive psychiatry. Let's move on to another topic. And this topic is very important. And here's the statement I will make, and then I will back it up with evidence. Most psychiatric disorders do not eliminate humor capacity. What they do is they block access. And this has been demonstrated repeatedly in studies of major depressive disorder, in which individuals continue to correctly interpret humorous stimuli. They recognize jokes. They identify the incongruity, even when their emotional responsiveness to humor is markedly blunted. Folks, this distinction matters greatly because capacity, as I've said before, implies identity, but access implies reversibility, meaning we can in fact reverse this challenge if we give it thought and we can offer our patients very logical interventions. So let's rephrase it. In other words, the brain still understands humor when the person is suffering from major depression. It's just that it doesn't respond to it with the same emotional resonance. So it's like the emotional volume knob is turned down. And that's why anhedonia deserves special attention here, because as we know, anhedonia is not just sadness. It's a loss of pleasure and anticipation and motivation. And what we want to do to reverse anhedonia is to find ways, sometimes multiple ways, of enhancing reward learning and effort-based valuation. So here's the key clinical insight. Humor is often one of the last pleasures to disappear in anhedonia and one of the first to return. Is that not great news? Now, we do need to talk about something uncomfortable but necessary. Because you see, not all humor is healthy. There is a dark side to humor. And research on humor styles distinguishes between what's called affiliative and self-enhancing humor, which are associated with better psychological well-being. But there is such a thing as aggressive or self-defeating humor, which are associated with increased distress. They're also associated with increased interpersonal conflict and perhaps even suicidality. Oh no, humor isn't just one face. It's like Janus. There is a light side to humor. There's also a dark side to humor. And individuals with certain personality states, particularly who are quite antagonistic or disinhibited, are often likely to use humors in a way to harm themselves or sometimes even harm others. And this is why positive psychiatry emphasizes how humor is used, not just whether it is used, because humor should be used to connect, not dominate. Patients often carry fear about humor. People often say, I was laughed at, and if I laugh, I might end up harming somebody else. People will make fun of me. But this is, of course, incorrect assumption on part of patients. Humor used the right way can be a very powerful tool for correcting their challenges. And at this point, we now arrive at a really important question, which is, how do we actually use humor? Not from a philosophical standpoint, not as a researcher, but really clinically. How do we ethically and effectively both use humor and teach our patients to use humor? Because humor in positive psychiatry is not a personality trait. It is, in fact, a skill. And like any skill, it can be taught, practiced. Humor isn't about performance. It's not about being funny. It's not about telling jokes. It's not about being witty or clever. Humor in this context is about perception. It's the ability to notice irony, absurdity, lightness. If you can notice humor, guess what? You are already practicing humor. And you know what else? Everyone qualifies. Now, in positive psychiatry, we think about humor interventions in two broad categories. We think about passive humor and active humor. Both are equally important, and people ought to perhaps think about engaging in both, perhaps starting with passive humor and then moving on to active humor. So, passive humor is exposure. Active humor is engagement. As I said before, both matter, and most patients, especially those with depression and anxiety and trauma or burnout, they really ought to begin with passive humor. So think of passive humor because, let me describe it. You could describe it as borrowing joy. So when our nervous system can't generate humor internally, we can, in fact, in a very healthy form, borrow it from external sources. So this might include things like watching sitcoms, perhaps watching short comedy clips, perhaps listening to humorous podcasts, or even reading humorous books, and engaging with light social media content. There is solid evidence supporting this approach, and meta-analysis of humor and laughter-based interventions have consistently shown improvements in mood and stress physiology and well-being and even social connectivity when humor exposure is passive rather than active. So, not for a second should we think that only active humor, producing humor, is how we can benefit from humor-based interventions in positive psychiatry. That is not the case. We start with passive, and only when we are ready, we move on up. It's also really important to remind people to sip humor, not binge on it. Because what we have now seen, if people engage in hour upon hour binging of humor, sitcoms, etc., well, it kind of defeats the purpose. So sip humor passively. Don't binge in it. Think of humor as nourishment, not anesthesia. We're not encouraging escape. We're encouraging presence with lightness. And this distinction prevents humor from becoming avoidant or dissociative experience. So we must also set expectations clearly. And patients, I think, do need to hear from us upfront. Well, we might say things like, you may not feel joy at first, but that's okay. We're not aiming for happiness right off the bat. We're aiming for noticing. You see what I just did? I encourage the patient to experience, to sip passive humor without forcing happiness upon them. Because amusement comes before joy and smiling comes before laughter. And this sequencing is supported by affective neuroscience models of reward recovery. There we go. We're back to talking about hedonia and anhedonia. Why don't we now move to active humor, but again, gently. Active humor does not mean creating jokes. It means training attention. Well, here is one of the simplest active humor practices you can offer your patients. You could say, once a day, notice one thing that feels even slightly amusing, ironic, or odd. That's it. That's it. Notice it. You don't have to analyze it. Heck, you don't even have to journal it. You don't have to create that scenario. All you have to do is notice. Because you see, just the act of noticing is in fact an engagement of the active part of the humor perception network in the human brain. Because this shifts our attention towards novelty seeking, safety seeking, and these are two core components of positive affective processing. Now, let's turn our attention to one of the most elegant interventions ever studied in human interventions, and that is called the three funny things intervention. The instruction is, dear patient, dear client, at the end of each day, write down three funny or amusing things that happened. Not jokes, just moments. What did you notice living, just living your life and observing? What did you notice that tickled your funny bone? And my goodness, so many randomized controlled trials have shown that this very simple practice, sometimes I've seen studies actually of just 3 days of this three funny things intervention can produce significantly positive results. Though many of the studies that I've looked at have been 7 days long, and here's the beautiful thing, even 6 months after this intervention was over, even 6 months after it, patients reported sustained improvements in happiness and reduction in depressive symptoms. Just think about it for a second. Just for a week, asking people to be observant about three funny things not only helped in those 7 days, but it seems to change the underlying neurobiology in such a fashion that the patient, that the individual gets benefits from things like depression and anxiety, and I was saving the best for last. And they had an improvement in their positive affect. This is such a cool thing to consider, that being humor-based interventions for all clinicians. Can we now start talking about ourselves? We've talked about patients quite a bit, but can we just chat about you and I and our colleagues, healthcare providers? You know, we clinicians must also attend to our own humor, because burnout and humor do not coexist for long. It's one or the other. One will eventually push the other out. The question you and I need to ask ourselves, do I want to live a life filled with burnout? Or do I want to live a life where humor is easily accessible? Because the truth is, for clinicians, humor practice may include things like allowing lightness when interacting with colleagues and patients, perhaps even noticing the absurdity in systems rather than internalizing it, perhaps even letting yourself off the hook with a smile without guilt, and perhaps reclaiming playfulness in order to make sure that we are sustaining ourselves for the long run. There really is increasing recognition amongst our profession that clinician well-being directly affects patient outcomes, and humor functions as a protective factor against emotional exhaustion. This is not my opinion. This is data published in JAMA by Western colleagues in 2016. So let's now address resistance, because patients are going to say things like, I'm not funny. It feels kind of stupid, man. I don't feel anything. You told me to write down three funny things or observe things or whatever. You know what? I don't feel anything. Let's not see these responses as barriers. They are signals. They're signals asking for us to respond, and we respond with validation, not persuasion. We can say things like, you know what? That makes sense. But please remember, we're not trying to make you funny. We're just trying to train your brain to notice the lightness in life again. And resistance softens when pressure from us disappears. And humor also functions as a social bridge. Many patients withdraw socially not because they don't care, but because they feel flat, right? And humor can reconnect human beings without demanding deep emotional conversations that patients simply don't want to engage in when they're not feeling well. So all of this counts. It all counts. It requires presence, though. So let's now step back and look at the bigger picture. Look, humor is not a treatment phase. It's a lifelong resilience skill. It's like sleep, folks. It's like physical exercise. It's like, well, social connection. No, humor does not eliminate suffering. That's not the purpose. But it does change how suffering is carried. And that matters more than we often recognize. So perhaps as we start ending our conversation on humor and its role in positive psychiatry, perhaps we should think about this thought. Psychiatric illnesses narrow life, but positive psychiatry expands it, and humor is one of the most humane expansion tools we have because it restores flexibility, it restores connection, it restores a sense of shared community. And perhaps most importantly, humor reminds us that even in pain, we're still alive. Humor is a skill set that we can teach our patients so that they too become practitioners of the fine art of living well in positive psychiatry. Folks, thank you so much for walking through this conversation with me. This is a very important topic for me, not just professionally, but personally as well. Humor has been one of the greatest gifts that I have received in life, and I so cherish it. And I really want patients to engage in it for their benefit. Folks, this was Positive Psychiatry with Rakesh Jain. Thank you so much for being part of this podcast. Goodbye for now.